Good afternoon, everyone. I'm Sofiati Dian from Bandung, Indonesia. It is truly an honor to stand before you today. First of all, I want to express my deepest gratitude to organizing committee for providing me this opportunity, and also for Dr. Dede Gunawan to introduce our current situation about the CNS infection in Indonesia. So as we know that CNS infection refer to infection affected the brain and also the spinal cord. It can be caused by various of pathogen, including the bacteria, viruses, fungi, and also parasites. This infection, given the crucial role of central nervous system to our body, any infection affected it demands our immediate attention. Indonesia is a diverse and also very populous nation, and we face challenge when it comes to CNS infection. Including the challenge of being the second largest TB burden now, according to WHO Global Report 2022. I mainly work in Hasan Sadikin Hospital, the highest referral hospital in West Java, Indonesia. Estimated we encounter around 400 cases of CNS infection each year. Most of them came with fever, vomiting, neck stiffness, headache, seizures, and coma. Until now, we noted around 2,000 CNS infection cases. But this report in this talk, of course, I only cover a small part of Indonesia, but I still believe this is still valuable to share, because maybe this is the pioneer of meticulous and structured data collection. So in this talk, I would like to share about how we collect the data, common pathogens, risk factors, clinical presentation, diagnostic challenges, treatment and management, future direction, and I will close it with a conclusion. So since 2014, we use this electronic database. This is a free software where we can keep our research clinical data, including the radiology laboratory, from the blood collection, as well as from the CSF collection. This software make us possible to do the editing and also doing simple statistical analysis to control the data completeness, and even it can export the raw data into the statistical software such as SPSS, R, or Stata. So this is the layout of our RedCap. We have to log in using our username and password. This is very important to maintain the data security. Only authorized individual can enter and modify the information. We collected the demographic data, clinical radiology, and also the follow-up data until up to 2 years of follow-up. So we encounter a range of infection agents such as bacteria, viruses, fungi, and also parasites. Each of these agents give us a very specific challenge in terms of diagnosis, treatment, and also how we prevent this disease. We usually use international guideline such as TBM Consortium guideline to diagnose TB meningitis, and use CDC guideline to diagnose such as cerebral toxoplasmosis and neurosyphilis, and also the British guideline for encephalitis. So before 2019, we mainly focus on TB meningitis. However, later we also expanded our focus to other type of CNS infection, collaborating with Cipto Mangunkusumo Hospital in Jakarta, also the highest referral in the city. So as we are aware that CNS infection gave us a very unspecific sign and symptom, therefore we have to exclude around 258 patients because proven not to have TB, not to have CNS infection. We found such as stroke, brain metastasia, and also psychiatric disorder, NPSLA, and other kind of abnormalities. So out of 1,051 patients, we have around 38% of positive HIV cases. We usually do lumbar puncture and also brain imaging to our patient, except for the one who refuse or have a clinical contraindication. And we keep in touch with our patient, and we even visited their houses if we cannot reach them at least 3 times in a month for at least 3 consecutive months. So the range of loss to follow up in our cohort is around 11 to 15%. The most common pathogen in our cohort is tuberculosis, accounted for 44%, followed by cerebral toxoplasmosis at 16%. And there are a minor number of viral encephalitis, neurosyphilis, cryptococcal meningitis, brain abscess, and also other infections such as neuroleptospirosis, neurocysticercosis, and also rabies. Among all the TB meningitis patients, we get the microbiological confirmation test positive 45%. And the highest positivity rate comes from the gene expert at 82%. So here I will briefly tell you about 4 patients. This is very extraordinary. I think this is quite interesting. The first case is the female, 27 years old, came to Cipto Mangunkusumo Hospital with severe burning pain in the upper back, followed by the weakness of the extremities. And we did a serial lumbar puncture, and we observed that the predominant cell is shifting from the lymphocyte predominant into the eosinophilic predominantly. Therefore, we diagnosed this patient with eosinophilic meningitis. And in gross CSF appearance, we saw this angiostrangulus cantonensis. So it seems that this lady is like to eat sushi, but I believe in Vietnam this case is quite frequent. And the second case is a female, 32 years old, HIV negative, came to our hospital with very classic TB meningitis features, 7 days of fever, but she also experienced diarrhea and seizure, which very rare in our cohort in TB meningitis patient. And we also did the lumbar puncture, and it comes very classic for TB meningitis. But then in the, and we even find a positive culture from the CSF. But then in the batch-wise test of PCR viral panel, we also find a chikungunya positive from this patient. This case has been reported in American Journal of Tropical Medicine 2022. The next patient is female, 27 years old, HIV negative. Sorry. This patient is man, 32 years old, HIV negative, came with a severe headache, NRS 8 to 9, and she went to several doctors finding out what's wrong with him, but then she eventually come to our hospital, and we did a lumbar puncture, and we saw a positive result from the Indian ink staining. And this picture show us the halo appearance of Cryptococcus gattii. We gave this patient with fluconazole 1,200 milligrams. The headache is resolved, but unfortunately, 1 month after the administration of fluconazole, the severe headache come back, and we did a second lumbar puncture. But in the second lumbar puncture, we didn't find any positive result from the Indian ink, also from the LFA antigen examination. But we sent the CSF to be cultured for fungi culture. And then it turned out that this patient have a positive result for other growth of dermatase fungi. So it seems that this patient have a paradoxical response or paradoxical reaction and co-infection with other type of fungi. We continue the treatment of fluconazole in that patient, and now the outcome is quite good. Then the last or the final case is a male 61 years old farmer with the history of back pain, severe back pain and paraplegia. And he eventually come to our hospital. Upon examination, we also found an elevated of liver function, and also jaundice, and also a high level of urea in the blood, and a very low thrombocyte level. We sent the blood to have the MTA test, and it come back positive. And we diagnosed this patient as neuroleptospirosis. We gave this patient with doxycycline 2 times 200 milligrams for 7 days, and then the outcome is quite good, except for the paraplegia. It seems that it remained the same as we also find in this NCS examination. This patient have a very severe axonal and myelin destruction. So due to our outcome data, we able to identify several factors prognostic to the mortality, such as fever, high level of neutrophil both in CSF and also in the blood. And the strongest predictor for mortality is HIV status, and also the low GCS score at presentation. From the HIV group of patients, we also did some analysis, and we find out that the prevalence of HIV positive in our cohort is quite high, at 25%, with the median CD4 cell count is very low, 13, and they usually have higher mortality rate, 12 times higher compared to the one who HIV negative. This finding make us routinely now check for the HIV testing in every suspected CNS patient in Bandung. The second publication, also from the HIV positive group, we perform the cerebrospinal fluid real-time PCR for toxoplasma in the batch-wise CSF sample of a patient with suspected TB meningitis, and we saw that 32.8% of them is positive. The patient with this positive CSF PCR result have higher mortality compared to the one who have a negative PCR. This finding recommend us to also check for other pathogen in a group of HIV positive, especially in the advanced HIV. And the next publication, we check for every patient who have CD4 count below 50 for antigen cryptococcal in the blood. And it seems that positive result for this test predicting to cryptococcal meningitis. And this group of patients have a higher chance to die. Therefore, now we routinely screening for cryptococcal antigen, followed by lumbar puncture and preemptive antifungal treatment for those who are positive in advanced HIV group. We also face a diagnostic challenges in our side. Therefore, our colleague Lydia Haidir published several publications from this cohort. We compare the positivity or the sensitivity of several modality of diagnostic, and it seems that PCR have highest positivity rate compared to culture, liquid, and also culture solid, and also the staining. And we also try to implement Zilnison with cytospin as introduced by colleague in China. But then in our cohort, it seems that the sensitivity is not significantly higher than the original Zilnison or traditional Zilnison. Therefore, now we are not using this mode anymore. The one that we recommend to get the positive result from the microbacteriological test is higher CSF volume, because it is predictive for the positive result. Next, after 10 years of cohort, we also able to identify that using the liquid culture give us a faster result of mycobacteriological test, 14 days versus 33 days compared to Ogawa or solid culture. And we also did a whole genome sequencing to identify the drug resistancy. And it seems that our patients also have a quite high number of patients with multi-drug resistancy and also quinolone resistancy. If we see the lineage strains, it seems that the Indo-Oceanic lineage strains have the highest probability to have drug resistancy compared to other lineage. But then if it comes to multiple mutation, the East Asian lineage strains seems gave us the most frequent resistancy. So next, since 2019, we also use expert to diagnose our patient. Also, with this modality, we can also identify rifampicin resistancy. But now, recently, WHO also recommend us Expert Ultra. It said that Expert Ultra has a higher sensitivity compared to the original Expert. But we know that the cost is quite high and not available in a very large area in our country. Next is the one the publication tell us about the occurrence of paradoxical response in our cohort. We try to identify by doing a second time of MRE, 2 times of brain MRI at baseline and 2 months after the TB treatment. And it seems that in patient with TB treatment 2 months after administration, 89% of them showed worsen of brain MRI. The most common abnormalities is tuberculoma. It can be enlargement or more tuberculomas in the brain. However, this patient sometimes have no clinical worsen, and it's not predictive to the mortality. In terms of drugs, we have a concern about because we now using a TB regimen for TB meningitis similar to the one we use for pulmonary TB. We still use 2-month intensive phase plus 4-month continuing phase, 450 milligrams of rifampicin. But then, in fact, we know that rifampicin among all the TB drugs has a very low ability to penetrate the blood-brain barrier. Therefore, it's only 20% of rifampicin able to reach the site of infection. Therefore, we are concerned about how if we increase the dose of rifampicin to increase the survival rate of our patient. Therefore, we have been done several or a series of clinical trial. The first clinical trial held in 2012. Here we try to compare between standard dose of oral rifampicin 450 milligrams compared to IV rifampicin 600 milligrams. And it seems by increasing the dose 30% and change the route of administration by intravenous, we were able to decrease the mortality 15% of them. From this same clinical trial, we also able to identify the target values of rifampicin exposure in the CSF, and 160 milligram per liter exposure of rifampicin and maximum concentration 22 milligrams per liter in the CSF seems very promising to decrease the mortality of TB meningitis patient. We also, therefore, we held the second clinical trial. We compare the 600 milligrams IV rifampicin compared to 750 milligrams and 900 milligrams of rifampicin orally. And it seems that up to 900 milligrams rifampicin haven't reached the target attainment yet. Therefore, we aim to the next clinical trial that compare even higher rifampicin dose. So we have done the third clinical trial to compare the standard dose of rifampicin with 900 milligrams of rifampicin with rifampicin 1,350 milligrams. We gave the patient for 2 months and then continued by traditional regimen. And we followed the patient up until 6 months. And we observed that it seemed by increasing the dose of rifampicin from 10 milligrams to 30 milligrams, result in a more than proportional increase in the exposure and also the maximum concentration of rifampicin in the CSF. With this high dose of rifampicin, it seems that the adverse event is not really serious. 1 grade 4 adverse event and grade 3 adverse event resolved without discontinuation of rifampicin. And from the our analysis, a possible trend of improved efficacy also saw. Now we are in the middle of a third phase of a clinical trial with South Africa and also with Vietnam to implement this high dose of rifampicin to our patient. So as a conclusion from our cohort, we are able to answer some research question, including the HIV testing and high dose rifampicin seems safe life and is tolerable. But then we also realized that further investigation are needed for a better clinical service for TB meningitis and other CNS infection. Thank you very much.